Well, good afternoon. This session today is the session about abstract presentation, and it will include 4 abstracts, 10 minutes each, with 5-minute discussion after each abstract. And we will be starting first with I will go over the abstracts one by one. However, just briefly to tell you who are going to be presenting, Dr. Hussam Ghazi, Dr. Islam Al-Zahabi, Dr. Luay Al-Bin Saad, and Dr. Najla bin Ghashir. So I'm going to start with the first abstract. And the title of this abstract is Efficacy of Radio Frequency Ablation for Benign Thyroid Nodules. And the presentation will be by Dr. Hussam Ghazi, who is a lecturer of internal medicine at Mansoura Faculty of Medicine in Mansoura, Egypt. Dr. Ghazi, the floor is yours.
First of all, I'd like to thank the scientific committee and the organizing committee of the first Arab Thyroid Association conference for accepting my abstract. I am Hussam Araf Ramadan Ghazi. I'm a lecturer of internal medicine and interested in the field of interventional thyroidology. My abstract title is The Short-Term Efficacy of the Radiofrequency Ablation for the Benign Thyroid Nodule. First of all, if we'd like to talk about some backgrounds about the thyroid nodules. Thyroid nodules are very common, either to be seen in a clinical practice, to be examined during the physician, whatever the cause of examination of the neck, or it may be incidentally found. In the last 2 years, many of us have been consulted for CT chest, for example, which is accidentally discovered thyroid nodules. This is called incidentally found. So thyroid nodules are common. If we want to talk about the prevalence, unfortunately, we do not have accurate prevalence for the thyroid nodules in Egypt. But when we take some data from the Western countries, the prevalence, which is clinically palpable thyroid nodules, may reach up to 7% of the general population, while if we are doing ultrasound, it may reach in some studies up to 3/4 of the cases, up to 75% of the other population may have thyroid nodules and may be asymptomatic. As of all know that thyroid diseases are common in females, and its prevalence is increasing with age. If the thyroid gland are euthyroid and causing compressive symptoms or cosmetic disfigurement, till few years, there is no treatment apart from thyroidectomy. Radiofrequency ablation are a novel technique in which there is an alternating current, which is conducting through a needle, which is inserted in the tissue. This alternating current are causing thermal necrosis. So this is the idea. All of us hear about the radiofrequency in the liver, in the bone, in the prostate, in the uterus, but the recent part is the radiofrequency ablation in the thyroid gland. There is a lot of advantage when you talk about in comparison to the corneal treatment of the goiter, which is the surgery. There is a lot of advantage when you are comparing the radiofrequency with the surgery. First of all, there is no scar. It is unfortunately, when you are facing female which is complaining from disfigurement from a goiter, it may be complicated by scar either due to physician made or either due to keloid or the nature of healing of the patient. We are ensuring, if it is well done, that there is no chance for the parathyroid injury. All of us are clinicians and we are seeing a case of post-thyroidectomy hypoparathyroidism. This may be difficult and very difficult in treatment. We are not removing the gland, we are just smalling the size, so there is no need for lifelong replacement with levothyroxine. This is done under just sedation or mild anesthesia. There is no need for deep anesthesia or intubation. There is no hospital stay, just 1 or 2 hours after the procedure. It is a minimal time, so it is safe for the patient, elderly and with chronic illnesses. And if it is it's done by well-trained person, it is of minimal complication in comparison to surgery. The primary objective of our study is to explore the safety and the short-term efficacy of radiofrequency ablation in reducing the size and volume of benign thyroid nodule as an alternative to the thyroidectomy. This is a pilot study. We included a 30 patients. 26 of them are females and 4 of them are males. The mean age are 36 years. 24 of them are euthyroid and 6 of them are having hyperthyroid. They are autonomous functioning toxic or thyroid nodules. The procedure, for those who are not familiar with the radiofrequency, the procedure, we are explaining to the patient that we are doing thermal necrosis, and this takes few weeks to notice shrinkage of the size of the thyroid nodule. We are not removing the gland, we are shrinking the size to decrease the compression and decrease the disfigurement. We should taking at least 2 fine needle aspiration or 1 true cut biopsy to make sure that its Bethesda classification is benign. We should assess the patient for the bleeding diathesis, and if the patient are taking anticoagulation and antiplatelet, there should be consideration about this to avoid developing hematoma. The needle is inserted. The best we are using it in our protocol. The best is to insert the needle from the medial part here to the through the isthmus, which is called trans-isthmic approach. We are inserting the needle from the isthmus, from the medial part through the lateral part. If the nodules are on the right side, the operator should be here. If the nodule is on the left side of the isthmus, the operator should be at the head of the patient. We are using the which we are inserting the needle to the posteromedial part. We starting to ablate the most deep part, then became superficial. We are starting from the medial part to the lateral part with a caution, because we are having a dangerous areas here and dangerous structures here to be avoiding its injury, like the vagus nerve and the carotid sheath and surrounding. Our results actually is marvelous. The mean volume of the nodule before starting the radiofrequency are about 20 milli. After 1 month only, the mean reduction of the volume are 40%. After 6 months, the mean reduction of the volume are about 80%. Compressive symptoms are significantly decreased. The 6 cases which is having hyperthyroidism, the autonomous functioning thyroid nodules, turned after a few weeks euthyroid, and we are stopping the drugs. And only 1 case was developed transient loss of transient hoarseness of voice, and it is improved spontaneously. I'll just share with you, to the sake of time, just share with you one of the best cases in which giving me promising results. These are females. If you are not seeing here, this is a scar of previous thyroidectomy. She developed a huge thyroid nodule, are reaching about its volume about 120 milli. Recurrent after thyroidectomy, mainly cystic. We aspirated here about 80 milli of hemorrhagic fluids, and this is the nodule before we are starting the radiofrequency. About 3 months only. If you are not seeing here, this is a marked reduction in the volume size, and after 6 months, the volume of the nodule, which is about 120 milli, turned after 6 months to 20 milli only. Our drawbacks of the study that we are needing a more number, we are needing a long-term follow-up, and we are needing more accurate and more sophisticated assessment and questionnaires for the compressive symptoms and the quality of life. Mr. Chairman, dear colleagues, to summarize my paper and my abstract, radiofrequency ablation are a novel procedure to treat and reduce the benign thyroid nodules who are causing compressive symptoms or cosmetic disfigurement. It is FDA approved and its position in the guidelines is growing. It could be used for the benign euthyroid thyroid nodules or the autonomous functioning thyroid nodules. The best results are seen in the cases less than 4 centimeters. It is very promising in comparison to surgery. It is a minimally invasive with a low complication. The main issue of the radiofrequency is the cost, as the needle is very expensive. At the end, I'd like to thank the organizing and scientific committee for this conference, and wish you all the pleasure, and thank you.
Well, thank you very much, Dr. Hussam. This was excellent, and the results you are sharing with us are impressive. We have a few minutes for questions and answers. However, I will start off myself with one question, and my question is about your trials. Do you have any long-term follow-up on these patients? Say after the 6 months period, what happens? Is there any possibility of recurrence or regrowth? And what is the largest size nodule one can consider for radiofrequency ablation?
Good morning, good afternoon, Mr. Chairman, and good afternoon, dear colleagues. Actually, for me and my cases, there is still no long-term follow-up more than 6 months. But from the trials, there is from the Korean trials and from Italian trials and Brazilian trials, the long-term follow-up up to more than 5 years, it shows that there is no regrowing for the nodules, except if there is a false results in the fine needle aspiration and it was underlying follicular neoplasm. So there may be some of the recurrence. So this is for the first question. My patients, I know I do not have till now long term because the radiofrequency ablation is just introduced in Egypt from 2019, December 2019. So it is still recent in Egypt. Regarding the best size, actually there is no agreement, no generalized agreement or recommendation or strict, but the universal agreement from the expert are about the 4 centimeter. Usually, if the nodule is less than 4 centimeter, it needs 1 session of radiofrequency, and usually the results will be good and marvelous. But sometimes we have some cases more than 4 centimeter, but it may need another session after 6 months. So the best size is less than 4 centimeter.
Okay, good. Any question from the audience? If not, so I have a question again about the smallest nodule for ablation in terms of size. Is there any size, minimal size that one can use as a cutoff point for deciding whether to use the ablation or not?
Yes, sir. If we are talking about the benign nodules, we are just treating compressive and cosmetic symptoms. As I told and as I said before, the cost is an issue and it is an expensive. So if the nodule is less than 2 centimeter, usually there is no compressive symptoms and usually it is not noticed, and unless it may be ethnic. So the cutoff less than 2 centimeter, usually it is asymptomatic and discovered incidentally by the ultrasound. But there is some Korean trials, but till now it is not FDA approved on the micropapillary thyroid carcinoma. They are ablating micropapillary thyroid carcinoma with size less than 1 centimeter. But here in my papers and in Egypt only, we just using the benign for compressive and cosmetic disfigurement only. For this, it is the cutoff not less than 2 centimeter.
Yes, I have a question for you from the audience, and the question is, how is the patient selection done in the study? Are there any criteria for inclusion or exclusion?
Yes, sir. As I said, the inclusion criteria, they are, all of them are above 18 years old. We are making sure by the ultrasound that the ultrasound criteria is making us comfortable. It is thyroid 2 or thyroid 3 only. And we are taking 2 fine needle aspiration to make sure that its Bethesda classification is 2. This is just benign colloid materials. There is no suspicious for follicular neoplasm. Any degree of suspicion in the ultrasound, either hypoechogenicity or some sort of calcification, we are excluding the patient. Any suspicion in the Bethesda classification, either 3 or above, we are excluding the manifestations. The only inclusion is the compressive or cosmetic issue for the patient. But if there is a nodule, maybe 3 or 4 centimeter, and it is not causing compressive or any cosmetic disfigurement, we are not including the study patient in the study, and we are not recommending to do radio frequency. It is just for follow-up.
Okay, good, good explanation, nice presentation, really impressive, good work. We're awaiting more data and more studies. And thank you for the presentation, Dr. Hussam Ghazi. Thanks a lot. So now we move on with the meeting, and the next presentation will be by Dr. Islam Al-Zahabi. Dr. Islam Al-Zahabi is Associate Professor of Surgical Oncology at the Oncology Center in Mansoura University in Egypt. And this presentation is also an interesting one, and it is entitled Endoscopic Thyroidectomy: 5 years experience of an Egyptian tertiary care center. So a nice topic, awaiting for the presentation for Dr. Al-Zahabi. If Dr. Zahabi is ready, the floor is yours.
My name is Dr. Islam Al-Zahabi, Associate Professor of Surgical Oncology at Mansoura University Oncology Center. Firstly, I'd like to thank the organizing committee and the Arab Thyroid Association for accepting my request for oral presentation. My topic today will be about our experience in endoscopic thyroidectomy at our oncology center at Mansoura University. Our experience honestly dates back to the beginning of 2017, since when we performed more than 180 cases. A brief background about the topic of endoscopic neck surgery. We know that the minimally invasive surgery has been applied in almost thyroid surgery since 1980s. And it was limited to regions where there is naturally occurring cavity, like the peritoneal cavity or the pleural cavity, and no one thought about insufflating the subcutaneous tissue until Gagner came in 1996 and performed his first endoscopic subtotal parathyroidectomy, and he insufflated the subcutaneous tissue, and he succeeded in performing the operation in about 5 hours. However, the patient suffered from massive surgical emphysema, but the patient resolved conservatively within a few days. Gagner definitely has many contributions in the field of laparoscopic and endoscopic surgery. He was the first to perform the first laparoscopic adrenalectomy for Cushing syndrome, the first laparoscopic pancreatectomy, and the first transgastric cholecystectomy, and also other contributions in bariatric surgery. Regarding the classification of minimally invasive thyroid surgery, you can classify it into 3 types: mini incision, non-endoscopic, making a small incision. Number 2, endoscopic, which are either video assisted, in which you are making a small incision and use the retractors, the self-retaining retractors, to create a space. And number 3 is the pure complete endoscopic approaches, in which we use typically a CO2 for insufflation and for working space creation. And this is the type which we adopted in our center in Mansoura University. And last type is the robotic approach. Another important classification of endoscopic thyroidectomy is according to the site of care entry to your target. If you reach your thyroid via the neck, this is called direct cervical approaches. If you reach your thyroid via from outside the neck, like the chest wall, like the axilla, like the post-auricular area, like the oral axis, this is called indirect extracervical approaches. And typically, these approaches are more preferred by us and for the patients because it avoids visible scar, and also it reduces the instrument interference. The general advantage of endoscopic neck surgery lies in its cosmetic superiority to the open approach. Number 2, the minimal stretching and compression in the tissues. Number 3, reducing the incidence of hyperesthesia, paresthesia, and discomfort. But in our study, we found no significant decrease in hyperesthesia and paresthesia in endoscopic approaches over the open approach. Number 4, definitely the magnified view, which helped in teaching your young colleagues. Number 5, the short post-operative stay, the minimal analgesic requirement, and the quick return to normal activity. Also, we didn't find a significant difference between the endoscopic and open approach in this item. Regarding the disadvantages, the main disadvantage lies in its inherent technical difficulty in the endoscopic approach because we lack the direct palpation, manipulation, and small working space. Number 2, the long operative time and steep learning curve. Number 3, the CO2 insufflation complication. But this complication could be removed or could be alleviated totally if you use a low insufflation pressure below than 10 millimeter mercury. Increased cost due to equipment usage, multiple scar in case of conversion, but again and again, selection is very important. You have to select your cases in order to not to need to convert to open. Number two, the gaining much experience decrease the rate of conversion. Number six, limitation like large lesions, thyroiditis, previous surgery, irradiation, malignancy. However, again, better selection and with gaining much experience, you can perform endoscopic thyroidectomy upon large lesions and in patients with thyroiditis and patients with Graves and patients with malignancy. Lastly, the extracorporeal implantation of hypoplastic amyoplastic tissue. We didn't find any case in our study regarding the extracorporeal implantation. However, it is reported in 2014. Regarding the technique, we are using standard endoscopic instruments. We are creating and maintaining the working space either by self-retaining retractor or CO2. But in our experience, we adopted the CO2 insufflation, and we don't have self-retaining retractors. Number three, the approaches either direct cervical, as I mentioned, or indirect extracervical. Our experience was in the axillary and the axillobreast, and in the anterior chest wall and the transoral approach. These are the approaches we adopted our center. These are some images of the self-retaining retractors, which is used in endoscopic thyroidectomy. Regarding our experience in Oncology Center, Mansourian University, we performed more than 180 cases of endoscopic thyroidectomy, about 30 cases of endoscopic submandibular thyroidectomy via chest wall approaches, about 25 cases of endoscopic neck dissection, chest wall approach, endoscopic parotidiectomy, and the endoscopic assisted parotidiectomy, and endoscopic parathyroidectomy. These are some of our publications. Like this is the first one about endoscopic submandibular thyroidectomy. This is about endoscopic thyroidectomy and endoscopic parathyroidectomy and endoscopic cervical lymph node dissection, and lastly, comparative study between endoscope and the open in patients with oral cancer. These are some of our patients. This is my index case of endoscopic thyroidectomy, which have a left thyroid lobe nodule. We performed left hemithyroidectomy via the axillobreast approach. You can see the site of the three pores, two in the axilla and one in the breast. This is another case of transaxillary endoscopic thyroidectomy using three pores in the anterior line. This is one of the cases of the anterior chest wall approach in which we performed endoscopic total thyroidectomy. This is a case of transoral endoscopic thyroidectomy via transoral approach. This short video will show the simple steps of endoscopic thyroidectomy for a patient with right thyroid lobe nodule. This is the first step, which is creation of the working space. I'm creating the working space below the platysma via the subplatysmal plane. We can see this is the subplatysmal plane, and then I go upwards until I see the sternocleidomastoid muscle, as you see. Then after that, I complete my dissection till I see the pretracheal muscle, Again, this is the creation of the working space. To make it faster, this is the sternocleidomastoid muscle, as you see. And this is the omohyoid muscle. I am going between the two pillars of the omohyoid and the sternohyoid muscle. This part is the lower part of the carotid triangle, and this is the common facial vein. As you see, this is the common facial vein. The first entry to the thyroid loop will be via the plane between the omohyoid muscle. This is the omohyoid, and this is the sternohyoid muscle. I will go through the space or the plane between the omohyoid and the sternohyoid muscle, as we see, until I reach the lateral aspect of the loop. As you see, this is the lateral aspect of the loop. After I reach the lateral aspect of the loop, I will start my dissection between the true and false capsule. This is the capsular dissection between the true and false capsule. After I dissect between the true and false capsule, I will shift my dissection downwards towards the lower loop, the lower pool of the thyroid, as we will see, attacking the lower pool first. In endoscopic thyroidectomy, via this approach, I prefer to attack the lower pool first. As we see, this is the lower pool dissection. I expose the trachea. This white structure is the trachea, as we see. Then I start by dividing the anterior thyroid vessels. This is the anterior thyroid vasculature, as we see. The anterior thyroid vessels or the anterior thyroid veins are divided into two groups. The medial group, which is this one, could be sacrificed easily, could be cauterized easily because it is far away from the recurrent laryngeal nerve. I could sacrifice it easily. However, when you approach the lateral inferior thyroid vein, it's better to delineate it and identify it thoroughly, because usually, or in most cases, the recurrent laryngeal nerve lies beneath it. This is the lateral inferior thyroid vein, as we see. This is the lateral. Before you divide it, make sure that the recurrent laryngeal nerve is far away. Then, after I divide the lateral inferior thyroid vein, I will shift my dissection slightly laterally to see the inferior parathyroid gland. The inferior parathyroid gland is coming here, as we will see. I will identify the inferior parathyroid gland. This is the inferior parathyroid, and I will dissect it laterally and caudally and downwards until I identify the recurrent laryngeal nerve running beneath it. This is the recurrent laryngeal nerve. Okay, this is the recurrent laryngeal nerve. After exposing the recurrent laryngeal nerve, I will continue slide dissection of the small part of the recurrent laryngeal nerve cranially, and divide some of the branches of the inferior thyroid artery which runs medial to the recurrent laryngeal nerve. In order to cut it short, I will not complete the video, and I will go through to my conclusion. My conclusion is the endoscopic neck surgery is a useful addition to the head and neck surgeon armamentarium. With careful patient selection, endoscopic neck surgery is safe, feasible, with relatively less post-operative pain and superior cosmetic results than conventional open neck procedures. The fact that the procedure can be done endoscopically does not mean that it should be performed. However, I think that it will take a lot of work before we realize that endoscopic neck surgery is good and oncologic operation. But the trip to learn such a truth should be so interesting. And thank you.
Well, thank you very much, Dr. Islam. This was great. It was impressive, and I think let's wait for a few questions. In the meantime, I have a question. Since you've had many such operations, is there any size limit for doing this? First, the size. Second, what type of thyroid nodules? Do they have to be all benign nodules, or can you do the approach also for cancers, papillary or other cancers of the thyroid?
Assalamu alaikum. Thank you for accepting my presentation in the first Arab Thyroid Association Congress. Regarding the two questions has the same answer exactly. Because the most tedious point in the technique of endoscopic thyroidectomy is the difficulty. And you can overcome this difficulty by learning curve. So when you perform more and more cases, you gain much experience, you control your instrument more and more, you can manage and manipulate larger nodules. So definitely I started my experience in this field by performing endoscopic thyroidectomy for small nodules. I started by nodule 2 centimeters, then increased the size of the nodule when I gained much experience. And really, the experience, I felt that I reached my experience or my modest experience after I passed 100 cases. I think this is much more cases than reported in the literature, which reported 40 or 60 cases. But here in Egypt, I think you need more than 60 cases in order to be expert in that field. And really, after I passed the first 100 cases, I felt that I'm more confident to perform endoscopic thyroidectomy for larger nodules. I really performed thyroidectomy for nodules exceeding 9 centimeters, and I have photos and videos for such cases. And regarding the second point, which is malignancy, sure, when you are confident enough, you can perform dissection on malignant tumors. And we all know that tumors of the thyroid, especially the differentiated thyroid cancer, are indolent cancer, calm cancer. I think it's best suited for endoscopic approaches. Unlike when we speak about cervical cancer, in which the laparoscopic approaches are condemned nowadays. But I think the era here in the thyroid gives you much more chance to perform your minimally invasive surgery, even in malignant cases. So I started performing endoscopic thyroidectomy also for malignant cases, for small cases of papillary thyroid cancer, for those cases with micropapillary, definitely. And what makes the technique more and more reproducible and more easy for thyroid cancer cases is that I can perform total thyroidectomy even from a unilateral site.
Well, this is very nice. I was wondering, I wish you shared with us the details of your publications about the number of adverse events and side effects and long-term follow-up and so on. In a nutshell and briefly, can you tell us about that? I know the time did not permit, and you had to show the technique, which is very interesting. Can you briefly share these points with us?
I will cut it short. In order to start endoscopic thyroidectomy, firstly, don't be afraid of insufflation of the subcutaneous tissue, for sure, and don't hesitate. All the complication of CO2 insufflation could be abolished totally if you maintain the insufflation pressure less than 9 millimeter mercury, and this is very, very true. This is number one. Number two, the most difficult point is how to deal with the structures in this narrow space. You have to control your instrument very well. You have to learn very well in order not to injure structures that you don't know. And we all know that the most common complication in surgery is the misidentification. And misidentification problem can be solved easily by more and more experience. You got to learn the technique, you know the color, the direction of the structures, you can avoid any complication. Alhamdulillah, yani complication of injury I didn't find except for the recurrent laryngeal nerve. And the recurrent laryngeal nerve injury I faced in my early cases due to neuropraxia caused by the current of LigaSure. I accustomed to use LigaSure, and you have to make sure that you are a quite far distance from the recurrent to avoid the heat injury. And I learned the lesson, and I now, if you look to the video, I put a gauze directly over the recurrent after I expose it in order to protect it. The parathyroid affection usually sometimes seen in total thyroidectomy, but برضو alhamdulillah, all cases were reversible, were temporary hypocalcemia. The most silly complication may be the hypothesia or paresthesia in the chest wall region, also can be avoided if you avoided injury of the supraclavicular branches of the cervical plexus. And lastly, some contracture in the muscle of the sternomastoid, also which eventually disappear with time and with some physiotherapy.
Well, this was great. This was really impressive. And thank you, Professor Islam, and looking forward for new updates and new publications about your kind of innovative approaches for thyroidectomy. And thank you so much for this beautiful presentation. And now we move on to the next speaker. And the next speaker is Dr. Olay Al-Bin Saad, who is an assistant professor at King Faisal University in Saudi Arabia. And the title of the presentation is the appropriateness of thyroid lobectomy as an initial surgery for preoperatively detected unilateral multifocal papillary carcinoma. It's a common condition that we encounter as endocrinologists and thyroidologists. And we will be listening to Dr. Loay to see what he's going to be sharing with us this afternoon. And the floor is yours, Dr. Al-Bin Saad.
It is my glad to be here, and I want to thank the Arab Thyroid Association for inviting me to speak about my abstract. My name is Dr. Loay Al-Bin Saad. I am a breast and endocrine surgeon. I'm assistant professor of surgery at King Faisal University in Al-Ahsa. My topic today is about the appropriateness of the thyroid lobectomy as an initial surgery for preoperatively detected unilateral multifocal papillary thyroid cancer. I have no disclosure. In introduction, well-differentiated thyroid cancer is the most common thyroid malignancy. comprising over 90% of all thyroid cancer. The overall 5-year survival of differentiated thyroid cancer is excellent. It's almost about 97.9%. And that of low risk, which mean by stage 1 and 2, almost 100% overall survival. Papillary thyroid carcinoma may present as a unifocal solitary tumor, but also can include 2 or more anatomically separated foci within the thyroid gland, which is described as multifocal papillary thyroid cancer. The current guidelines issued by the American Thyroid Association include patients with multifocal papillary thyroid cancer within the low-risk category. Although some studies have shown that the prognosis of multifocal papillary thyroid cancer is significantly worse than that of the unifocal papillary thyroid cancer. And therefore, the multifocality often managed as a high-risk factor for disease severity, which require more aggressive treatment. Our objective of this study is to investigate whether preoperatively detected unifocal, unilateral multifocality in papillary thyroid cancer patients associated with local regional recurrence and prognostic outcomes. The study design, it is a retrospective study around 510 cases at the Asan Medical Center in South Korea between 2000 and 2005. 236, 62, and 14 cases were excluded due to the bilateral multifocality and modified radical neck dissection and tumor size more than 4 centimeters, respectively. So a total of 198 patients were divided into 2 groups according to the type of surgery they received. Lobectomy group, which is 62 patients, and total thyroidectomy group, 136 patients. The follow-up strategy and the clinical outcomes. Neck ultrasound was performed within the first 6 and 12 months after initial lobectomy or total thyroidectomy. In addition to that, it was routinely repeated at 12 months to 24 months interval. And the fine needle aspiration cytology was used to confirm the structural recurrence if the indeterminate or suspicious thyroid nodules were found in the contralateral lobe or the lymph nodes. So our result of this study, this is the clinical pathological characters of patients who received lobectomy or total thyroidectomy in cases of preoperatively detected unilateral multifocality papillary thyroid carcinoma. Here we can see that we divided the patients to 2 groups, lobectomy group 62 patients and total thyroidectomy group 136 patients. The tumor size was significantly lower in the lobectomy group rather than the total thyroidectomy group, which is almost 1.6 plus minus 0.8 centimeter. The extrathyroidal extension also was more in the total thyroidectomy group. The stage, obviously, it is more more advanced in the total thyroidectomy group. Also, we studied the clinical pathological characters of patients with an initial thyroid operation who had no recurrence versus the recurrence in cases of preoperatively detected unilateral multifocality. The non-recurrence group, almost 174 patients, and 24 patients had recurrence. We can see that the tumor size is more than 2 centimeters in the recurrence group, while the non-recurrence group, the tumor size is almost 1.3 centimeters. The size of the lymph nodes is more in the recurrence group in comparison with the non-recurrence group. And the extrathyroidal extension was more in the recurrence group rather than the non-recurrence group. After that, we did a univariate and a multivariate analysis of the risk factor associated with the recurrence in cases of preoperatively detected unilateral multifocality papillary thyroid cancer. The univariate analysis showed that gross extrathyroidal extension and lymphovascular invasion and the tumor size and lymph node metastasis and extrathyroidal extension are all related to the recurrence, all with the p-value less than 0.05. The multivariate analysis showed that lymphovascular invasion and the extranodal extension and the lymphovascular invasion and lymph node metastasis significantly associated with recurrence. After that, we did a cross analysis of recurrence according to the surgical extent by tumor size and lymph node metastasis. We found that if the size is more than 2 centimeters, the metastasis will be more, and the lymph node metastasis will be more. It is almost 34%. And less than 2 centimeters, the recurrence is significantly lower. So, in discussion, still the prognostic significance of multifocality is a controversial issue. Multifocality was considered as a high risk factor in previous studies for structural persistent recurrent disease. Potentially, multifocality in the presence of aggressive histological features, most notably the gross extrathyroidal extension and lymph node metastasis with a tumor size of 2 centimeters, may influence the outcome. In our study, the patient diagnosed with unilateral multifocal papillary thyroid cancer after lobectomy didn't receive completion thyroidectomy, but were observed during the follow-up. So lobectomy may be considered as an alternative treatment to total thyroidectomy for patients with preoperatively detected unilateral multifocal papillary thyroid cancer with the diameter less than 2 centimeters. Although the recurrence in the contralateral lobe after lobectomy could be diagnosed in unilateral multifocal papillary thyroid cancer, it would not increase the local regional recurrence and the mortality rates. Patients with lymph node metastasis or extranodal extension should undergo thorough examination of the lateral neck node area preoperatively during the follow-up. The limitations of our study: this was a retrospective study with a selection bias stemming from the inclusion of patients based on their characters. Additionally, preoperative neck CT was not routinely checked, even for patients with poor prognosis for recurrence with lymph node metastasis or the presence of extranodal extension. Lobectomy was not chosen for tumors larger than 2 centimeters in diameter, according to the previous guidelines from 10 to 15 years ago. So this is my topic today. I want to thank you for giving me the opportunity. Thank you very much.
My name is Dr. Najla Ben-Gashir. I'm pleased to be here presenting the finding of our study titled Clinical Pathological Characteristics of Pediatric Thyroid Carcinoma, UAE Multi-Center Experience, performed in a patient cohort from Sheikh Khalifa Medical City and Tawam Hospitals in Abu Dhabi. So the objectives of our study were to describe the clinical presentation, the preoperative assessment, surgical treatment, and follow-up of pediatric patients that aged 18 years or younger over a period of 11 years from 2010 to 2020. And these were exclusive for diagnosis of thyroid carcinoma. And this was a retrospective chart analysis of the clinical pathological data across the SKMC and TAWAM hospitals, and ethics approval was granted for the study. Overall view, we had 31 patients as a total number, and majority of patients were diagnosed in the period from 2016 till 2020, with a statistically significant increase in the number of patients. And the range of age for our patient was from 7 to 18 years, with a median age of 17 years. Majority of our patient, 90.3%, aged between 10 and 18 years. And this corroborates with the findings of the some of the USA studies for the age distribution of their patients. And we had 1 to 5.2 male to female ratio correlating with findings of a majority of the studies. Interestingly, our male patients were at a younger age when diagnosed with thyroid carcinoma compared to the female patients. And 13 patients had a diagnosis of chronic lymphocytic thyroiditis in the background. 3 patients had a confirmed positive family history of thyroid carcinoma. And this is distribution. We had 5 patients aged 11 years or less compared to 26 older patients. And we had 11 patients diagnosed in the first half of the study period compared to 20, almost double of the numbers in the latter half of the period. We have 5 male patients compared to 26 male patients, and a majority of the thyroid carcinoma was of the papillary thyroid carcinoma type. Only 4 patients minimally invasive follicular thyroid carcinoma, correlating with most of the studies. And we had almost equal distribution of the tumor size as of below or above 2 centimeters. And 16 patients, we had multifocal disease, and 7 patients with extrathyroidal extension. And the below table shows the distribution of the tumor in the different areas of the thyroid. For the preoperative assessment, 21 out of 31 study patients presented with a thyroid lump or cervical mass amounting to 77.4% of patients, which is the most common presentation of TC described. Most of the patients' mean duration of presentation from start of symptom diagnosis was 12.73 months. And 21 patients had an abnormality detected on physical examination, and 3 patients had palpable cervical lymph nodes. And fine needle aspiration was done in 20 out of 31 patients and proved useful, yielding a typical through to Bethesda 4 to Bethesda 5 and Bethesda 6 diagnosis, which helped indeed in further managing of the patients. So out of 31 patients, 30 patients underwent surgical treatment, and 22 patients had an initial thyroid total thyroidectomy surgery, and 8 patients had initial hemithyroidectomy and then underwent completion thyroidectomy. So in total, 29 patients had total thyroidectomy, and only 1 patient had hemithyroidectomy without further surgery. Only 1 patient left without treatment because she had metastatic pulmonary disease and she went beyond curative surgical intervention. And the mean duration from initial surgery to re-surgical intervention was 5.3 weeks. So our practice is in line with the standard recommendation for surgical treatment. Post-operative course, 19 patients had radioactive iodine, and all patients had levothyroxine hormone suppressive treatment. The post-operative complication rate was very low. Only 10% of patients had complication, mainly hypocalcemia that resolved or was transient. Only one patient had a significant complication of iatrogenic ptosis, which did not resolve at 1 year follow-up mark. So we had 30 patients underwent surgical intervention, and 27 had papillary thyroid carcinoma diagnosis, as we said, and this is a pie chart with further breakdown of the histologic subtypes. So extrathyroidal extension was seen in 7 patients, and 4 patients had macroscopic extrathyroidal extension that matters. Tumor size range from 0.3 to 6 centimeter. Majority of our patients, 80%, had macroscopic tumor more than or larger than 1 centimeter. And these patients anyway would have undergone further investigations according to the American Thyroid Association recommending FNA sample for nodules of this size. So 23 patients who had surgery had lymph node sampling, and 16 lymph nodes had positive lymph nodes for metastatic carcinoma. And 60% of the male patients had positive lymph nodes compared to 46% females with positive nodes. And the male patients had a lower mean age at diagnosis compared to females. Here is the breakdown. To the left, we have the female patients with positive lymph nodes, the blue bar, and negative lymph nodes with the orange bar. And we can see relatively the male patients had more rate of positive lymph node involvement. And here is overall, we have 71% of our patients had one or more unfavorable histologic feature at time of diagnosis, that is namely multifocal disease, positive lymph node in 16 patients, or extrathyroidal extension in 7 patients. And therefore, this supports the fact that pediatric thyroid carcinoma tends to present as a more advanced stage or have an aggressive course. And so 15 patients had N1 status, 15 patients had N0 status, and only 1 patient had M1 status. So overall, the clinical stage, because of the age, favorable age group, that majority of the patients presented as M1 stage, whereas the single patient with lymph node with pulmonary metastasis presented at M1 stage. Follow-up was available in these patients for a mean duration of 37 months, ranging from 1 to 120 months. All patients were alive during the follow-up period, and we have 35.5% patients followed for more than 5 years. However, the prognosis was very good, where the majority of patients, 80.6%, were in complete remission at the end of follow-up. 5 patients showed evidence of recurrent or progressive disease. These include 4 patients with local thyroid bed recurrence or cervical lymph node recurrence, and 1 patient with metastatic pulmonary disease that continued to progress. So for the predictors of survival, we have 2 interesting findings: that patients aged over 11 years had a lower risk of recurrent or progressive disease, and as you can see in the progression-free survival diagram here. And for tumor size adversely affected the progression-free survival, where high tumor dimension were found to increase the risk of lower progression-free survival, shown in this diagram. So in conclusion, thyroid carcinoma is a reality in pediatric population, and therefore a clinical examination should include thyroid assessment in children and adolescents. And thyroid carcinoma in children and adolescents can be quite aggressive and presents with advanced stage disease. However, it has an overall good to excellent prognosis. However, when a young patient presents with a thyroid nodule or abnormality in the region of the thyroid or cervical lymph node, suspicion of thyroid carcinoma should be considered and further investigated with the imaging modalities and plus minus thyroid FNA sample. And this is among the first studies to address this disease group. And we hope that there will be more future studies to compare the characteristic of thyroid carcinoma in pediatric population against those in adulthood in UAE population. Thank you.
Well, thank you so much, Dr. Najla bin Qashir. And I apologize for the technical problem where I got disconnected. I didn't get the chance to present Dr. Najla Al-Ghashir, who's a consultant anatomic pathologist at Sheikh Shakhbout Medical Center in Abu Dhabi, United Arab Emirates. And your presentation about clinical pathological characteristic of pediatric thyroid carcinoma was quite impressive, and you are UAE expert in this field, and I really thank you for sharing the data with us. And we have some time for a few questions. I should mention that Dr. Luay Al Bin Saad could not join us for personal reasons, so we did not get the chance to get any questions and answers on his session. I hope that with Dr. Najla's presentation, we get more questions. Let me start off by myself, Dr. Najla. I don't know if you're on. Yes. First, congratulations for the study and the data. And being a pathologist, is there anything that one would be able to detect in children versus adults that makes the cancer, the papillary cancer, behave more aggressively in children than others? Is there any underlying features that one can detect in children? And my other question is, why is it that in general it tends to be more aggressive in children than in adults, the papillary thyroid carcinoma?
Thank you. Thank you very much for the question. From histopathologic point of view, I think from this study and from literature review on the pediatric thyroid carcinoma, from histological characteristics as for the tumor type, majority of the tumors tend to be of the classic type, and there is a proportion of the papillary thyroid carcinoma as being the major histologic type of being of the some cases, I mean, maybe increased percentage of cases being of the tall cell variant, which by itself is a histologic type associated with a tendency for more aggressive behavior. I think this is as far as the, or also sometimes you may see some percentage of diffuse sclerosing variant of papillary thyroid carcinoma. And also speaking of the underlying molecular and genetic abnormality, something that we did not touch upon in our study, and maybe it needs further investigation, is the presence of probably more propensity of the thyroid carcinoma in children to be associated with underlying mutations such as RET gene rearrangement or perhaps BRAF mutations. And also there has been a lot of literature speaking of the association of thyroid carcinoma as such with the risk of radiation, as happens in some areas of the world when there was an increased risk of exposure to radiation. And I think in our study, we could not find a risk of radiation in any of the patients, apart from a single patient who had papillary thyroid carcinoma as a second malignancy. He was a 17-year-old boy who had a previous diagnosis of Ewing sarcoma in a pelvic region, and he underwent radiation to a non-cervical area, so we cannot associate the link. But yeah, this is, I think, my understanding of probably the special characteristics of pediatric thyroid carcinoma. I hope this answers your question.
Yeah, it's an interesting answer you gave, and I really appreciate that. And I know you're a pathologist, and you know, I wanted to ask you about the prognosis in children with papillary carcinoma. Is there anything from your angle that will kind of help the clinician, the thyroidologist, kind of predict, or can tell a priori what is the prognosis of a thyroid cancer in a child in terms of follow-up?
Yeah, thank you for a very important question. Just something that I would like to elaborate a little bit. In our study, I mean, overall, there has been a consensus that the prognosis for pediatric thyroid carcinoma, the differentiated type, tends to be excellent or overall very good, and something I think which we have also noticed in our study, despite the fact that a proportion, I mean, significant proportion of our patients presented with a locally advanced disease, the prognosis was very good. We had only one patient who presented as clinically stage 2 disease, and that was the single patient with metastatic pulmonary disease. The other 4 patients, 2 of them had evidence of recurrent disease past the 6-month post-operative mark, whereas the other 2 patients have evidence of progressive residual disease. I think I remember at 3.5 months period, and the other patient was 14 months post-operatively, and these patients were cured by resection. So despite the fact that they present at a relatively advanced stage, the overall prognosis is good, and the tumor tends to follow an indolent course. And this is what we have witnessed in our study. And perhaps I think the main message that we would like to convey through this study is be aware of the thyroid carcinoma, because something that is a simple observation, because usually cancer is suspected less in the pediatric population. But we want to highlight the message that in any child or adolescent present for clinical examination, pay attention to the thyroid. Early detection is the most important part in treating the patient and maximizing the chance of cure.
Thank you so much, Dr. Najla. And with this presentation, we conclude our session. We had 4 interesting presentations, really outstanding, all the 4 of them. The Arab Thyroid Association usually would like to choose 2 winners for this abstract presentation. For me, the 4 of them, 4 presentations, all of them, the 4 of them won this afternoon. They were outstanding and superior. And it was unfortunate that Dr. Loay could not be with us for questions and answer on his great talk. And unfortunately, we have to choose 2. And this year, the choice is for 2 non-endocrinologists who happen to be among us, and we are lucky that they added a flavor to our meeting. And the 2 winners, even though it was a very tight kind of race, The two winners are Dr. Islam Al-Zahabi, who shared with us his vast experience with endoscopic thyroidectomy, quite impressive procedure and data. So congratulations, Dr. Islam, for having won with us. And the second winner, again, equally did a great job and tackled on an interesting topic. And the winner would be Dr. Najla bin Ghasher, who is a pathologist with interest in thyroid carcinoma, and who also shared with us her experience on the clinical pathological characteristics of pediatric thyroid cancers. So, the two other presentations also were fantastic. Anyway, the call was to choose 2 out of 4, and we had to choose. And thank you all for being with us, for attending this excellent abstract presentation. And I really appreciate the effort of the speakers. And there were many other abstracts that were also considered for presentation, but we had to choose 4. And out of these 4, we also elected to choose the 2 winners, Dr. Islam and Dr. Najla, and have a good rest of the afternoon, and take care, everybody. Thank you very much.